The last diagnosis in this afterload category is the possibility of this extracardiac cause of distributive shock. This is defined as severe peripheral vasodilation. Decreased SVR leads to decreased mean arterial pressure, and low mean arterial pressure causes organ ischemia. Significant vasodilation also causes blood to pool in the periphery and not necessarily be sent to organs. Initially, you can have relative hypovolemia, which causes a decreased preload to the heart. The causes of distributive shock are frequently anaphylaxis, sepsis, neurogenic shock, or anesthesia vasodilation. Specific to anaphylaxis, you may see bronchospasm or the presence of a rash. For sepsis, you may see a fever or an infectious source. For neurogenic shock patients, you may have one who has spinal cord trauma or a recent spinal anesthetic. And then as it relates to anesthesia as a cause, the presence of recent vasodilating agents. The treatment here, of course, are pressors, fluids, and then treating the underlying cause. What are some of the ways with echo that we can identify distributive shock? Well, you can look with your views at the mid-esophageal forechamber and transgastric short axis views. Some of the features you may see are that your left ventricle is hyperdynamic with a normal left ventricular end diastolic diameter, and that your RV size is frequently normal as long as you've been resuscitated and not underfilled as it would be in a patient with hypovolemia. The cardiac output, if it's calculated, should be normal or high here. When there's significant decrease in SVR, the patient compensates with an increased cardiac output. Some of these patients may have less markers of volume responsiveness after their initial volume resuscitation as well. This can be one of the most clinically relevant slides here is how to actually differentiate hypovolemia from distributive shock. We already mentioned the left ventricular end diastolic diameter being less than 3.5 centimeters and underfilled if there's a deficit in preload, but being normal in patients with low afterload. The RV is underfilled in patients with low preload because there's less volume in the body, whereas patients with low afterload can have normal RV size. Some of the indicators of volume responsiveness that might make us think more highly of low preload being the culprit of the shock state is LVOT VTI variability greater than 12 to 15% and SVC collapsibility greater than 36%. And then cardiac output is low in patients with low preload, and it's normal to high in patients with low afterload.